Good morning, respected dignitaries and delegates. I'm Rima, hereby to present a paper on lateral rectus palsy, a case series. Lateral rectus palsy is the most common isolated palsy due to long peripheral course of the nerve. The abducens nucleus is located in the caudal pons at the level of the facial colliculus. In the vicinity of the abducens nerve nucleus or facial nerve loop and pontine gaze center, so nuclear lesion of the abducens nerve is extremely rare. The injury of the abducens nerve can occur anywhere along the long course, so differential diagnosis of the lateral rectus palsy occasionally demands thorough investigation to find the proper cause. For didactic reasons, isolated lateral rectus palsy is divided into traumatic and non-traumatic. Isolated traumatic lateral rectus palsy, if partial, recovers in almost all patients, and if complete, in approximately 1/3 of the patients, no other diagnostic workup is necessary and treatment is conservative. However, non-traumatic isolated lateral rectus palsy is a diagnostic challenge in daily routine and demands thorough investigation. The purpose of this study is to present 7 cases of isolated lateral rectus palsy with complaints of diplopia, of which 6 are non-traumatic and 1 is traumatic, and also to discuss the differential diagnosis and to suggest which neuroimaging and laboratory investigations are appropriate in which occasion. It is an observational case series of lateral rectus palsy done during October 2017 to March 2018 in Medical College Hospital. All the demographic details and clinical profile of the patients were recorded. Diabetes and hypertension were considered, and the patients underwent diplopia charting, force duction test, and MRA. These are the clinical findings of our patients. The case number 1, which is a male of age 55 years, diagnosed with cerebrovascular accident with right hemiparesis, and the neurological examination showed left lateral rectus palsy. His CT findings are non-contrast MR angiography or left vertebral artery occlusion, and MRA findings showed hyperacute left hemipointed hemorrhages with perilesional edema and microbleeds involving the temporal lobe on the right side and thalamus on the left side. There are no risk factors, and the cause of the 6th nerve palsy is ischemia. And the other patient of age 85 years, male patient, diagnosed with CVA with left hemiparesis and Broca's aphasia with right lateral rectus palsy. His MRA findings showed acute infarct in right thalamus, inframedial part of the temporal lobe, parasagittal right occipital lobe with right PCA territory infarct. And he has risk factors of both diabetes and hypertension. The third case, which is a female of age 23 years, diagnosed with postpartum hemorrhagic Cva, presented with bilateral lateral rectus palsy with papilledema. Her CT findings showed hemorrhage in the right capsuloganglionic region with intraventricular component, and acute hemorrhage involving head of right caudate nucleus and anterior aspect of the right lentiform nucleus, which extended to 3rd and 4th ventricle with mild hydrocephalus. And the risk factors are history of pregnancy-induced hypertension. In another patient of age 55 years, male, with a head trauma, presented with a right lateral rectus palsy, and his CT findings showed left frontal contusion and frontoparietal acute subdural hematoma, and there are no additional risk factors. The 5th case of age 16-year female, diagnosed with idiopathic intracranial hypertension, presented with bilateral lateral rectus palsy with papilledema, and her MRI findings are normal, and the cause of lateral rectus palsy is increased intracranial pressure. The 6th case, which is a 54-year-old female with diabetes, presented with left lateral rectus palsy, and a 25-year-old female with diagnosed as Tolosa-Hunt syndrome, presented us with right lateral rectus palsy, and her MRI findings showed a plaque-like soft tissue disease involving the right orbital apex extending to involve the cavernous sinus, which enhanced on post-contrast imaging. The incidence of lateral rectus palsy is 11.3 in 10,000 individuals, with a peak in the 7th decade of life, according to a study done by Patel S. And the pontine lesions rarely cause isolated lateral rectus palsy because all pontine pathways and nuclei are located very near each other. All of the published cases of isolated pontine lateral rectus palsy were caused by a lesion of the abducens nerve fascicule, and multiple sclerosis is the most frequent cause, stroke or tumors being extremely rare. Our patient number 1 is the example of fascicular pontine lateral rectus palsy due to stroke. Lateral rectus palsy as a consequence of cavernous sinus pathology is well known, and diseases like Tolosahun syndrome, carotid cavernous fistula or tumor are the most likely causes. If lateral rectus palsy in such instances is isolated, as in our patient number 5 and 7, symptoms like headache and tinnitus should prompt emergency neuroradiological investigation.